Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS Quality Program Consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hello, Dr. Mingle.
Good morning, Hadley. Good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we start, I do want to remind our listeners that they can leave their questions in a comment on LinkedIn or YouTube, or you can email them directly to us at hello@minglehealth.com. Our first question today is from Corinne. Corinne asks, can you help me understand EMA clusters and MVPs? How are they similar? How are they different?
Thanks, Hadley, and thanks, Corinne. Great question. There's a third topic I'll toss into the mix. Any discussion comparing EMA clusters to MVPs needs also to consider specialty measure sets, and I'll define these terms in a few moments. First, each of these three topics help in different ways to achieve two functions critical to quality submissions. First, they help to guide measure selection. Providers often need help to find measures applicable to their specialties. Second, they need help to determine when a submission of fewer than 6 measures should be permitted without penalizing a provider or group scoring potential. It's neither desirable nor fair to penalize a provider or a group practice when they can't find 6 measures that apply to them to analyze and to submit. Each of these methods differs in how they approach these two functions. Now, EMA stands for Eligible Measure Applicability. In EMA for 2022, there are 42 measures that sort into 12 distinct clinical topics. Each group of measures mapping to its topic is considered an EMA cluster. EMA analysis is applied by Medicare after submission to analyze submissions containing fewer than the required 6 measures. When any submitted measure maps to one of the EMA clusters, Medicare assumes the provider could have and should have submitted all of the other measures in the cluster. After EMA clusters are accounted for, to the extent that Medicare does not identify other measures that should have been submitted, scoring is adjusted to eliminate any penalty for too few submitted measures. EMA is primarily a retrospective analysis of a short set of measures. EMA topics tend to be around a clinical topic rather than a specialty. The cluster could be representative of a subspecialty, or it may cross specialty lines. Now, specialty measure sets, each includes the measures CMS thinks are applicable to the specialty. EMA clusters can look like specialty measure sets, but tend to be a single clinical topic that can be within a specialty or bridge multiple specialties. Specialty measure sets are intended to be used proactively as a guide for the specialty provider or group to choose appropriate measures, but they are also treated as EMA clusters when Medicare retroactively analyzes submissions with fewer than 6 measures. For the 2022 performance year, there are 47 specialty measure sets into which sort 96 different measures. The number of measures that sort to each specialty ranges from between 2 up to 62 measures. 42 specialty measure sets contain 6 or more measures. 5 specialty measure sets contain fewer than 6 measures. Dentistry has 2, cardiac electrophysiology has 2, hospitalists are at 5 measures, radiation oncology has 3, speech and language pathology has 5. Now, if a provider or group submits all the measures in a specialty measure set that has fewer than 6 measures, the submission is scored as complete with a reduced denominator. So no penalty in these cases for a small measure set. So for those specialty measure sets that have more than 6 measures, a provider or the group just needs to choose any 6 of the measures in that specialty group. But if a specialty measure set has fewer than 6 measures, Submitting each of those measures is a complete submission for that provider or group. It's scored with a smaller denominator as a complete measure set with no penalty for the small measure set. Now, the final addition to this discussion is MIPS Value Pathways, or MVPs. It's the newest addition along this theme. MIPS Value Pathways have been under development for several years and just became available for use for the first time for the 2023 performance year. MVPs can have a specialty focus like specialty measure sets, or they can have a clinical topic focus like EMA Clusters. Like specialty measure sets and EMA Clusters, each MVP defines a complete submission measure set. Once you've chosen an MVP to submit, no other measures need to be added for a complete submission. Unlike specialty measure sets and EMA clusters, each MVP includes cost measures and practice improvement activities that relate to the same specialty or clinical topic. Medicare has proposed a development and ramp up schedule that will steadily increase the menu of available MVPs, and potentially as early as the 2028 performance year end the current MIPS program that they are now calling traditional MIPS and transition completely to MVPs. After transition, we should expect EMA clusters and specialty measure sets to no longer be needed or supported. Corinne, I hope this helps to bring some clarity to these issues. I'll have a lot more to say about MVPs in the weeks, months, and years ahead of us. Stay tuned.
Thank you, Dr. Mingle. Our next question is from Carol. Carol wants to know, for promoting interoperability, the PDMP, the Prescription Drug Monitoring Program, query is now a requirement. However, our providers don't prescribe any controlled substances. We have thus far not enrolled in EPCS as we didn't need it, and it was expensive through our EHR product. Our EHR vendor has told me that in order to be enrolled in the PDMP query, we must also enroll in EPCS. This seems very silly since our infectious diseases and lipid clinic physicians don't ever prescribe controlled substances. I have been unable to find an exclusion. Is there an exclusion that I've missed? Or do we have to spend the money for something we don't use just to stay compliant for promoting interoperability?
I think the news for you, Carol, is good. And this is a great question with about 6 components to the answer. 1, what is a PDMP query? 2, what is EPCS? 3, what does it take to pass the PDMP measure in the Promoting Interoperability Performance category? 4, what controlled substances are covered by the PDMP measure? 5, is there an applicable exclusion for this measure? And 6, how do I apply all of that to your specific situation? So first, what is the PDMP query? PDMP stands for Prescription Drug Monitoring Program. It's usually a statewide solution, and there's progress toward a national roll-up of these programs into one master program. Programs tend to require participation by pharmacies and recruit prescribing providers to use the service. At last tally, 49 states, the District of Columbia, and Guam have operational programs. Missouri is the final state to be working toward implementation and may be up by this time, but I haven't found specific reference to it yet. Just that they're working on it. The intention is when writing a prescription for controlled substance, the prescriber will check the PDMP for record of controlled substance prescriptions previously provided to the patient. The intention, of course, is to identify when a patient is acquiring controlled substances from multiple sources as a sign of abuse. Procedures for accessing the program can vary from state to state and can include phone inquiries, direct web-based login and query, integration directly between the PDMP and the EHR, integrations between the EHR and a national PDMP clearinghouse, and specific programs might accept logins from the prescribing provider or from the provider staff. Next, what is EPCS? EPCS stands for Electronic Prescribing of Controlled Substances. It's governed by both the DEA and by individual state boards of pharmacy. It requires appropriate DEA credentials credentials to prescribe controlled substances. It requires proof of identity by some authority that can vary from region to region. It's kind of like proving your identity for a passport or for the newest real ID driver's licenses. And it requires two-factor authentication when you write prescriptions to electronically sign the prescription. So, what are the requirements of the measure? The measure is addressed as an attestation. You answer to the question: has the required action been performed at least once by the individual provider or by at least one provider in the group? Yes or no? The required action is to query the local PDMP to access the patient's history when prescribing a controlled substance. Now, the rule states a MIPS eligible clinician has the flexibility to query the PDMP using data from the EHR in any manner allowed under the state law, meaning it does not have to be integrated with the EHR. It doesn't have to be automated unless that is the only way your local program permits query. It does not require credentials for EPCS. It's applicable to electronic or manually written prescriptions. Now, what controlled substances are covered by the PDMP measure? This changed for the 2023 submission year. Prior to 2023, it only applied to the Schedule II drugs. Starting in 2023, it adds Schedules 3 and 4 drugs to the list. Now, don't view this as being more restrictive. It's actually more lenient. Since it only requires one query in the year in order to pass, you can now pass by querying for a Schedule 3 or 4 drug if you don't prescribe Schedule 2 drugs. Now, the next question is there an exclusion that you can use or I can use in my practice in which I do not prescribe controlled substances? There are three exclusions that apply to the PDMP measure. One, if you're unable to electronically prescribe Schedule 2 opioids and Schedule 3 and 4 drugs in accordance with the applicable law during the performance period. Two, you're excluded if you write fewer than 100 prescriptions during the performance period. Three, if querying a PDMP would impose an excessive workflow or cost burden prior to the start of the performance period. Now, how can we apply all of this to your specific situation? We know that you have a specialty practice dealing with infectious disease and as a lipid clinic. You have an EHR. You electronically prescribe, but you don't prescribe Schedule 2 drugs. What do? Well, first, you do not need to implement electronic prescription of controlled substances. You don't prescribe them. It's a waste of time and money. You don't need to be electronically interoperable with your physician or your patient drug monitoring program, even if you prescribe controlled substances. The key phrase in the rules is you can query the PDMP in any manner allowed under state law. If your local PDMP permits you to log in through the internet and manually search the database, that qualifies. You have to interface if that is the only way your PDMP permits query. You only need to do it once to pass the measure, and only one of you needs to do it once. You can't just check the PDMP on your prescription for a non-scheduled drug. The specifications are specific to scheduled drugs. But don't think only about Schedule 2 drugs. Starting in 2023, you can query your Schedule 3 and 4 drugs as well. If any provider in your group prescribes a Schedule 3 or 4 drug and logs into your local PDMP to check the drug history on that patient, you can attest yes to this measure. Now, if you still can't pass this measure on a Schedule 3 or 4 drug, you can use one of the exclusions. You probably can't use the fewer than 100 prescriptions exclusion. It applies to all scripts, not just controlled substances. The 100 prescriptions is not an annual number. It is counted only for the selected performance period, which can be short as 90 days. Now, I like the unable to electronically prescribe exclusion for you. If you consider my scope of practice doesn't give me the opportunity to prescribe controlled substances, I think it fits reasonably well. But equally applicable is the excessive workflow or cost burden exclusion. Certainly, it's excessive to spend anything on functionality you don't need and won't use. So, thank you very much for that question. I hope I've helped. Good luck to you in this application.
Excellent. Thank you, Dr. Mingle. Corinne and Carol, thank you for the great questions. If you have a question for Dr. Mingle, please leave it in the comment on LinkedIn or YouTube, or send us an email at hello@minglehealth.com. And as always, Dr. Mingle, thank you for sharing your insights with us today.
Thank you, Hadley, and thanks to all of you for the great questions. I want to be helpful and I want this to be useful to you. Don't hesitate to correct me or to supplement my answers. Share your experiences, ask your questions. We can be smarter together.